ABGs look scary at first glance, but once you follow a simple, systematic roadmap, they become one of the most predictable investigations in medicine. Your entire approach rests on 5 steps. The trick is to master one step before jumping to the next, like climbing stairs, not skipping them. The classic 5-step approach. Each step represents a crucial decision in ABG interpretation. Mastering one at a time ensures accuracy as you move forward. Step 1. Identify the pH. If it's below 7.35, that indicates acidemia, and if it's above 7.45, that indicates alkalemia. Step 2. Identify whether the disorder is metabolic or respiratory. Look at the key values. A low bicarbonate points towards a metabolic problem, while a low PCO2 suggests a respiratory cause. Ask yourself, which value is pushing the pH in this direction?
Metabolic disturbances are compensated by the lungs, and respiratory disturbances are compensated by the kidneys. Understanding whether this compensation is appropriate is the key to uncovering mixed disorders and moving confidently through ABG interpretation.
Step 3. Check compensation. If the compensation matches the expected formula, there is a single disorder. If not, suspect a mixed disorder. For metabolic problems, there is usually rapid respiratory compensation. For respiratory problems, compensation is slower and metabolic, 12 hours to 5 days. When it comes to compensation, we rely on a few key formulas. For metabolic acidosis, Winter's formula guides us in predicting the expected PCO2. For metabolic or respiratory alkalosis, separate compensation rules help us understand how the body adjusts. These formulas are essential for spotting when something doesn't add up. In metabolic acidosis, expected PCO2 is 1.5 times bicarbonate plus 8. In metabolic alkalosis, it's 40 plus 0.7 times the rise in bicarbonate above 24. In respiratory acidosis, bicarbonate rises, plus 1 in acute and plus 3 to 4 in chronic for every 10 mm Hg increase in PCO2. In respiratory alkalosis, bicarbonate falls, minus 2 in acute and minus 4 to 5 in chronic for every 10 mm Hg drop. That's your quick guide. Step 4 is checking the anion gap, which matters only in metabolic acidosis. It explains why bicarbonate has fallen. A high gap means extra acids are accumulating, like lactate, ketones, or toxins. A normal gap means bicarbonate loss from kidneys or gut, such as diarrhea or renal tubular acidosis. The anion gap identifies the cause and guides proper management. At this stage, you've identified whether the disturbance is metabolic or respiratory, and you've classified any acidosis as high anion gap or normal anion gap. You've also pinpointed metabolic alkalosis and the primary respiratory disorders. Now it's time to look deeper and uncover any mixed or hidden acid-base disorders. Step 5. The delta gap. This calculation is to correctly diagnose a high anion gap metabolic acidosis. The delta ratio is change in anion gap divided by change in bicarbonate, delta A over delta HCO3. Interpretation is to detect hidden disorders. Less than 0.4, you also have a hidden normal gap acidosis. Between 0.8 and 2, this is pure high gap acidosis. Greater than 2, additional met alkalosis. Advanced tools include the urine anion gap, UAG for NAGMA. If UAG is positive, kidney renal cause is likely. If negative, it's extrarenal, often diarrhea. The osmolar gap helps in mysterious hogma, such as with alcohol ingestion or unexplained altered sensorium. Take-home frame. Use the patient history for important clues. Stick to the 5 steps for every ABG. Always calculate the anion gap for metabolic acidosis and the delta gap for HAGMA. Use UAG for NAGMA and osmolar gap if toxins are suspected. Formulas help solve mixed disorders.